This is Drugs Affecting the Cardiovascular and Renal Systems, Part 1. Nursing 517, 617, Module 3. Hypertension represents a major modifiable risk factor for coronary artery disease, also known as CAD, heart failure, which we'll abbreviate with HF, stroke, chronic kidney disease, which is CKD, and dementia. As prescribers, we need to follow guidelines that stress the importance of standardized, accurate measurement of blood pressure and recommend office-based measurements for diagnosis. The newest clinical guidelines focus on patient outcomes based on the understanding that if patients take their medications, it is more likely to have good clinical outcomes than if artificially selected numeric targets create falls, hypotensive episodes, and generalized fatigue. So, again, the newest clinical guidelines focus on patient outcomes based on the understanding that if patients take their medications, they're more likely to have good clinical outcomes. And if they don't, they're probably going to have some issues like falls, hypotensive episodes, fatigue. Targets for blood pressure readings must be individualized, so it's not cookie cutter. So here you'll see some of the recommended target ranges. Hypertension is greater than or equal to 140/90. You see the normal blood pressure ranges and hypertensive blood pressure ranges. So hypertensive targets, blood pressure targets for treatment, if somebody is 18 to 64, then their target is less than 130/80. If somebody is 65 to 79, their target for treatment is less than 140/80 if it's tolerated. So sometimes you may have a patient that comes in and their blood pressure is like 160/100 and you're trying to get it down. Of course, you're going to bring that down very slowly. But once you get to less than 140/80, that's optimal. However, some patients may not tolerate that. So it all depends on the patient. And if they're greater than 80 years and up, then their target range, they have a little bit more flexible range. So 140 to 150/80 is a target for them. Okay, let's go over some treatment guidelines. After serial blood pressure measurements indicate a persistent reading of 150 to 160 systolic, individuals without deep vein risk should be instructed on diet and exercise. Medications are initiated after diet and exercise. So what is this saying? Your patient comes into the clinic, they come in one day, their blood pressure is 150/90. First time you've ever met the patient says, hey, I've never had any blood pressure problems. Are you going to start them on medication? What this is saying is you're going to start them on diet and exercise or give them lifestyle changes first. But you'll bring them back, have them come back, do serial readings, and then you can make a decision on if this patient needs to be treated. Now, they can check their blood pressure cuff at home if you trust their cuff. I mean, if you calibrated their cuff with your cuff and it's working. But if not, you want to bring them back into the clinic and have them get serial readings done. The target values are below 140. Systolic blood pressure are not rigidly enforced if the patient is compliant with medication and exercise, especially in older adults. So the target values are below 140 systolic. But it just kind of depends on your patient. Even after you start them on medication, you want to continue to emphasize lifestyle changes, lifestyle changes, lifestyle changes. Drill that into them. So giving them a prescription and sending them out the door, they still need to maintain all the diet and exercise that they were doing before they had to start medication. So there's different stages of hypertension. And this is with a high cardiovascular risk. Stage 1 is 140 to 159 over 90 over 99. So treatment is usually started with a diuretics like a thiazide type. You can also consider ACEs or angioconverting enzyme inhibitors, which is an ACEI or an ACE, an angiotensin receptor blocker, which is an ARB, a calcium channel blocker, or a combination of the two. Stage 2. That's if someone comes in and their blood pressure is greater than or equal to 160 over 100. Usually they're going to get a 2-drug combination. So they'll probably get a thiazide type and an ACE or an ARB or a beta blocker or a calcium channel blocker. If they have compelling indications like heart failure, diabetes, stroke, CKD, then you want to consider diuretics, ACEs, ARBs, beta blockers, calcium channel blockers as needed, okay? So that's the treatment with hypertension and how we will treat somebody coming in. So if somebody comes in and they're in stage 2, they're earning 2 medications. So that's where you want to look. Somebody with stage 1, and I'll go back to show you, stage 1, you're going to consider 1 medication. Stage 2, you're going to consider a 2-drug combination. So it could be 1 pill that's a combination pill, depending on their insurance. Some insurances don't like to pay for those, and so patients have to take 2 pills. But remember, someone with stage 1 will not be initiated on 2 medications. Someone with stage 1 will not be initiated on 2 medications. Okay? All right, moving on to heart failure. So there's different stages of heart failure. We have stage A, and you will not have to memorize these by stage, but you need to know what medications might be better. So someone with stage A, we can give them like an ACE. That's the drug of choice, right? An ARB is considered, but it's more expensive. So you would want to know that. If someone is stage A, then an ACE is the drug of choice. An ARB is considered, but it is more expensive. Stage B, ACE is for all the patients if they're stage B. An ARB for those who cannot tolerate an ACE, and beta blockers are suggested for most. Stage C would get an ACE and a beta blocker in everybody. They may get diuretics, Digoxin, or spironolactone. Stage D, Entresto, which is a newer medication. They may be using dobutamine by the time they're in stage D. They probably need a ventricular assisted device or a transplant, and they're probably being considered for hospice in stage D. So now that you know what medications are used to treat these different stages, let's talk about each one. So let's talk about the ACEs. So there's strong evidence for cardiovascular and cerebrovascular risk reduction, heart failure, and slowing of renal disease. Slowing of renal disease improves oxygenation to heart muscle, decreases inappropriate remodeling of heart muscle after a heart attack or an MI, or with heart failure. ACEs reduce effects of diabetes on the kidneys, which you should all be familiar with that. Okay, so let me repeat that again. Someone taking an ACE, ACEs reduce effects on diabetes, It reduces the effects of diabetes on the kidneys and improves insulin sensitivity. ACEs do not affect glucose metabolism or raise serum lipid levels. So, an ACE, inhibition of angiotensin converting enzyme, or an ACE activity, results in decreased production of both angiotensin 2 and aldosterone. ACEs can lower vascular resistance without decreasing cardiac output or the glomerular filtration rate. And it does not produce a reflex tachycardia. So that is the pharmacodynamics of an ACE. And again, you do need to understand pharmacodynamics. So some of the common ACE inhibitors, benazepril, captopril, enalapril, lisinopril, lisinopril. Do you notice something in common about those medications? It's the prils. So the ACEs are the prils. Some that you'll see very most commonly are lisinopril and benazepril and captopril, enalapril. However, although the initial dose of lisinopril is 10 milligrams daily, that's not normally the dose that you'll use for someone if you're just using it as a protective factor. Okay. So you don't have to have all of those memorized. Whenever I do want you to know a drug, and if you're gonna the starting dose and maximum dose, I will let you know. So ACEs are good when you're treating younger Caucasian patients, patients with angina, patients with diabetes, someone who's had a heart attack or heart failure. ACEs are not as effective in the African American population. So with patients with angina, it prevents formation of angiotensin 2 and decreases the pulmonary vascular resistance by decreasing retention of sodium in water and reducing extracellular fluid and preload. If you're using it in patients with diabetes, it prevents or slows nephropathy after a heart attack and heart failure. It's used for ventricular remodeling. And again, it's not as effective in African American patients, but when you combine it with a diuretic, then race is no longer an issue. However, 3 to 4 times greater risk of angioedema in African American patients. So you always have to be cautious. And then if you're treating an African American patient with an ACE and they tell you they always have a tickle in their throat or a cough in their throat, you probably want to discontinue the ACE. So adverse drug reactions would be that dry cough that I was just talking about, and that's bradykinin mediated. So they may just say, you're asking, hey, how are you doing with this medication? I'm doing good, doc, but I always have this little cough. If you've just given an African American patient an ACE and they're telling you about this little cough or little tickle, that's not a good sign. Another adverse drug reaction would be hypotension, of course, because you're lowering the blood pressure. They may experience loss of taste, angioedema, which that's a big one. They may have some blood dyscrasias, hyperkalemia, acute renal failure, pancreatitis, or jaundice. So some of the big heavy hitters that you're monitoring for in your African American patients, of course, is that little dry cough. You're going to check their potassium levels, right? If it can cause hyperkalemia, for sure. Check their kidney function as well. Okay. All right. So monitoring the ACEs. So there is a possibility of orthostasis within 1 hour of administration. So also tell your patient, do not double the dose if they miss the dose. If you miss the dose and you think about it later on and you're like, oh, let me take 2. You missed yesterday's dose. No, don't do that. Hypotension is one of the most common adverse drug reactions, and of course, that cough is common with some of the older generation agents. So let's move on to angiotensin 2 receptor blockers. So the angiotensin 2 receptor blockers, or ARBs, prevent binding of angiotensin 2 to receptors in kidney, brain, heart, and arterial walls. They inhibit the renin-angiotensin-aldosterone system, or the RAAS, the RAS, and cause a fall in peripheral resistance. There's no bradykinin-mediated cough like with the ACEs, so you don't really have to worry about that. The ARBs are considered alternatives for patients who cannot tolerate an ACE or become resistant. And many of the ARBs are combined with hydrochlorothiazide. So we will go over what most of the ARBs look like too. Now remember we talked about the CYP450? Let me give you some examples. So if you're using losartan, some inducers would be rifampin or barbiturates. And some of the inhibitors like lovastatin, Bactrim, fluconazole, sertraline, fluvoxamine, and fluvastatin. So you have to understand. So if you're giving losartan, what happens if that patient is taking losartan and Bactrim? Or what happens if they're taking sertraline and then they're prescribed losartan? So now do you understand why you need to understand the CYP450 inhibitors or inducers? Okay, so I could spell it out for you, but because the best way for you to learn is to go back and put the two together so you have a better understanding. Okay, and here are some of the common ARBs, or angiotensin 2 receptor blockers. The sartans, losartan, valsartan, candesartan, irbesartan, the sartans. So if you see one of those medications, you may not have to pick out the initial dose or the maximum dose, but you do need to recognize when you see an ACE, you need to recognize when you see an ARB. So you need to know, okay, these medications in this class, these are my ARB, but these are the ARBs, the sartans. You need to know if you're asked about an ACE on a test question, what would the ACE look like? Which would that be losartan? Would that be an ACE? Or would that be an ARB? So you do need to understand that. So some of the adverse drug reactions with ARBs, typically there's no problem with cough, but just like with the ACEs, you are going to monitor for orthostatic hypotension or orthostatic changes. Let the patient know, do not double a dose. And hypotension is, of course, one of the common adverse drug reactions. Why? Because we're trying to lower their blood pressure, but it might be lowered too much. Okay, and this is a new drug class. This is the Entresto. And it's known so far to decrease hospitalizations and death in chronic heart failure, especially those with an ejection fraction of less than 40%. And it's taken in place of an ACE or an ARB, not given with beta blockers such as carvedilol. So this is a new drug class. It's the Neprilysin inhibitors. So sacubitril and valsartan, which is also Entresto, increases renal blood flow and improves diuresis. It does require a 36-hour washout between an ACE, an ARB, or a beta blocker. So if this is a medication which you probably will not be giving Entresto, but you do need to know this. So if your patient is on a medication, now I say that, however, if you go and work at CIS, this may be something that you start. But your patient has to have a 36-hour washout between giving them Entresto. So if they were on an ACE, if they were an ARB, if they were on a beta blocker, they cannot start Entresto until they've been off of that medication for 36 hours. And this has been called a game changer medication because it's decreasing hospitalizations and death. Okay, so we are going to move on to calcium channel blockers. So calcium channel blockers functionally act as vasodilators, lowering the calcium influx into smooth muscles. Calcium channel blockers are the first choice for African Americans with hypertension and can be used as add-on medications for others. Let's talk a little bit about calcium channel blockers. So type 1 is the non-diphenhydropyridines. These affect conduction through the AV node and have negative chronotropic effects used in treating SVT. Okay, so type 1 are the non-dihydropyridines, okay, and that affects conduction through the AV nodes. Type 2 is the dihydropyridines, and that does not affect conduction through the AV node. So when you're using type 1, some of those medications might be the cardizem or Calan or the verapamil. On your test, you're always going to see generic names and not trade names. Type 2 do not affect conduction through the AV node. So that would be more like Procardia, amlodipine, felodipine, and they're metabolized by the liver in the CYP450-3A4. So let's do that again. Let's kind of go over that slide again. The type 1 calcium channel blockers, diltiazem, verapamil, those are type 1 used to treat SVT. Type 2, not affecting the conduction through the AV node, nifedipine, amlodipine, felodipine. You'll see probably amlodipine quite often. You'll probably write that medication. Now remember that is a type 2 calcium channel blocker. Some of the adverse drug reactions, they're very constipating. They may cause dizziness and headache. They may cause some edema or rash. They may even cause gingival hyperplasia. You do have to monitor. You want to avoid in patients who have heart failure and know that if you give a calcium channel blocker with an ACE, that combination decreases peripheral edema. You want to make sure your patients understand to avoid NSAIDs when they're taking calcium channel blockers, avoid alcohol, don't be in a jacuzzi alone because of the hypotension and the dilation that they can get, the heat, all that combined together makes it an unsafe situation. In patients who have reflux, those symptoms may get worse because of the decrease in the esophageal tone. Okay, and so now we will talk about cardioglycosides. Cardioglycosides, when we talk about that, we mainly talk about like digoxin. Digoxin is highly selective inhibitor of the adenosine triphosphatase or the ATP system. Inhibition of this pump results in sodium and calcium buildup inside the cell, which leads to increased contractility of the heart muscle. It is well absorbed orally, not extensively metabolized or excreted or unchanged by the kidneys. It has a half-life of about 36 to 48 hours. and reduce clearance with drug interactions. So one thing you need to know too is serum concentrations greater than 1 milligram per milliliter increases mortality. You want to start this drug off at the lowest dose possible. And I will tell you, unless you are working in the heart clinic, you probably will not be starting patients on digoxin. But you do need to understand it. New research shows digoxin may increase mortality in women. Benefits are best in patients with severe heart failure, enlarged heart, and third heart sound, and in patients who do not respond to ACEs and beta blockers. It is well absorbed orally. It's not extensively metabolized, excreted or unchanged by the kidneys, and again, that half-life is about 36 to 48 hours. In the absence of oral or IV loading, steady state is achieved in 4 half-lives or 1 week reduced clearance of digoxin with drug interaction. So that's like with amiodarone or quinidine. Some of the ADRs, the most common is nausea, vomiting, diarrhea, feeling a little bit sick to their stomach. They may have some fatigue. They may have visual disturbances, would be like a yellow vision and green halos around light. So if your patient is coming in talking about those halos, you definitely want to investigate. Usually you start off by finding out what medications they're on, if anything has changed, and you're going to refer that patient out. So you definitely have to monitor for digoxin toxicity, and it's based on both clinical and lab data. But any patient taking digoxin needs to be monitored for toxicity. You monitor their serum potassium levels and know that toxicity commonly occurs if the serum level is 2 nanograms or greater. So let's talk about some pharmacodynamics. So let's kind of go over some of the antiarrhythmic agents. Drugs for arrhythmias, you're going to consult with a cardiology team. Okay, if you're trying to manage arrhythmias, you're not going to do this on your own. Again, those working in cardiology clinics may have different levels of responsibility, but if you are working in a family practice clinic, primary care, you will not be the end-all be-all for any antiarrhythmic agents, but we do need to understand them. So some of the sodium, calcium channel blockers, quinidine, lidocaine, procainamide, you won't be prescribing that. You may do beta blockers for different reasons. Agents that prolong the duration of action, like amiodarone, that is not something you're going to prescribe in a family practice clinic or primary care. Pharmacological management of arrhythmias requires an office that is prepared, ready, and able to handle emergencies. Even though you may have a crash cart in your clinic, you are not going to be responsible or held responsible for starting these medications, and you won't be able to handle those types of emergencies, okay? So you're going to see patients that are taking these medications, maybe for depression, maybe for infection, maybe for anemia. So you have to be aware of the actions of the medications and the adverse drug interactions, but you are not going to be prescribing these medications. Okay, and let's go on to, oh, I went the wrong way. Okay, let me go back. Okay, so just a little bit about amiodarone. Amiodarone is a class 2 arrhythmic drug. The onset of action is about 2 days to 3 weeks. The duration of action is anywhere from 7 to 50 days. If you have a patient that comes in and they're on amiodarone, that patient should not be having grapefruit juice, okay? Some of the adverse drug reactions, there's so many interactions with other drugs, but amiodarone can cause like a blue skin discoloration. It may cause bradycardia, could have issues with the thyroid or even lung damage. Patients who are taking amiodarone need to be monitored for potassium, EKG. Again, because you won't be responsible for prescribing this medication, I won't be asking you about monitoring it because another clinic should be monitoring it. You should be aware of the adverse drug reactions, and there are very, very many, okay? So you will not be tested on adverse drug reactions or drug interactions on your test. So this is a specialty medication that I do not, unless you're working for a cardiovascular clinic, you probably will not be starting or monitoring this medication. One that you might be more or may be starting is nitrates. So they're all part of the vascular system. Relax, okay? So they may cause arterial dilation with higher doses, may decrease serum alkaline phosphatase, resulting in a decreased afterload. Together, these effects decrease myocardial oxygen demand and increase myocardial oxygen supply. So what about nitrates? They decrease myocardial oxygen demand and increase myocardial oxygen supply. They have little effect on the atherosclerotic coronary arteries. So what are some of the adverse drug reactions with nitrates? Headaches, orthostatic hypotension, especially they can cause syncope, and they can cause tachycardia. Headache may be severe and persist in about 50% of the patients. Hypotension may lead to decrease in diastolic filling pressure, and tachycardia may lead to a decrease in diastolic filling time. It can also cause contact dermatitis. So some things that you're probably more familiar with is the headache. So if someone is using like nitroglycerin cream, then if you're the family member or you're teaching the patient about the medication, you want to tell that person to wear gloves because if they get that cream on their fingertips, it may cause a severe headache, right? So with nitrites, there is concurrent use with vasodilators or with erectile dysfunction drugs are contraindicated. So you're not going to give nitrites to someone who's taking vasodilators or has ED. There could be additive hypotension with antihypertensive medications, alcohols, beta blockers, and calcium channel blockers. These are usually oral ointment or some transdermal topical systems. So headache, of course, is one of the big ADRs, hypotension, and contact dermatitis, right? Because it is something that is on the skin. So there are drug interactions with drugs like sildenafil, tadalafil, and vardenafil, which is Viagra, Cialis, and Levitra. It's contraindicated with those medications. You also want to be careful with patients who are drinkers. So, and there's many different routes for this medication. Nitrates are used for angina attacks, angina, stable or predictable angina. You want to tell the patient to take the medication exactly as prescribed. And if they're going to take it twice a day, it's going to be on like a 7 and 2 or 8 and 3 rather than like 10 in the morning and 10 at night. So they have to have a nitrate free interval of about 10 to 12 hours. So if your patient's taking it twice a day, it's either 7 in the morning and 2 or 8 and 3. It's not going to be 7 and 7 like normal. They do have to have that nitrate free interval of 10 to 12 hours. If their anginal symptoms occur at night, then they have the daytime free nitrate interval. The nitrate free interval is during the daytime. And tell them to make sure they're adhering to the expiration date on the bottles and not to open that bottle frequently because, don't open it and just look at the little pills. So if they're using a short-acting or sublingual nitroglycerin, they're going to have either 0.4 to 0.6 milligrams, and they'll take that every 5 minutes for up to 3 doses. Every 5 minutes for up to 3 doses. And when they're getting to that third dose, they need to be calling 911. If they have stable or predictable angina, then they're going to be taking a medication called isosorbide, and they're going to be taking about anywhere from 10 to 40 milligrams, 2 to 3 times a day. And if they're taking sustained release, it's only going to be daily. Make sure when they're storing their nitroglycerin, they keep it in a dark place, in a dark area. And they need to keep their bottles next to their body, like in a shirt pocket. Okay, now we're going to talk a little bit about hyperlipidemia. Atherosclerosis is a major cause of coronary artery disease. Lipoproteins all contain triglycerides, phospholipids, and cholesterol, which is the LDL. High density HDL and very low density, which is the VLDL. So the pathophysiology of triglycerides, the pathophysiology, the exogenous pathway involves absorption of lipids via the intestine, and the endogenous pathway, lipids originate from the liver. Okay, so we went over hyperlipidemia, and so some of the drug therapies for hyperlipidemia or for dyslipidemia would be the 3-hydroxyl-3-methyl-glutarol coenzyme A or HMG CoA reductase inhibitors. There would be fibrates, bile acid sequestrants, niacin, Zetia, and some other products. So those 3-hydroxyl, 3-methyl glutarol coenzyme A reductase inhibitors, those are drugs like lovastatin, pravastatin, simvastatin, and so forth. Fibrates, there's fibric acid derivatives like gemfibrozole. Bile acid sequestrants are those like cholesterol. Niacin's not really popular anymore. It used to be way, way back in the day, but not so much. Zetia is the most effective in combination with a statin. So there's all kind of other drugs on the market, but these are just some that we'll go over today. Do know that active liver disease is a contraindication for everything except for bile acid sequestrants. So if they have active liver disease, you are going to stay away from fibrates, statins, niacin, but it is okay to give them a bile acid sequestrant. So the statins. Rosuvastatin is the most potent of the statins. Statins block synthesis of cholesterol in the liver. by inhibiting the HMG-CoA reductase activity. Statins decrease levels of LDL, which is the bad cholesterol, by anywhere from 25 to 65%. Fully contraindicated in pregnancy. Rosuvastatin, again, that is the best, most potent, and it starts off at 5 milligrams and goes up to 20. Next comes atorvastatin. And atorvastatin has the best adverse drug reaction profile as well. And then it's simvastatin and lovastatin. So fully contraindicated in pregnancy. It may cause headaches, myalgia, some fatigue. Some people kind of feel just icky, yucky, like flu-like symptoms when they're taking it. They may even have some GI intolerance. Again, rosuvastatin is the most potent. Atorvastatin follows, then simvastatin and lovastatin. So, pravastatin is given at about 40 milligrams a day. For pediatric dosing, children 8 to 13 years may take pravastatin at about 20 milligrams a day. These medications are traditionally given in the bedtime or in the evening. May need to decrease these doses occasionally depending on some of the monitoring that you do. You should check their lipid levels in about 4 to 6 weeks, then about every 3 to 4 months until control is established. LDL levels guide the dose increases, so you need to be watching their LDL levels. You should have liver function tests before starting therapy, and 3 to 6 months later if there's any kind of hepatic disease, okay? You definitely want to educate your patient on lifestyle changes. Okay, and then we'll move on to fibrates. So the mechanism of action is inhibition of cholesterol synthesis, decreased triglyceride synthesis, inhibition of lipolysis in adipose tissue, decreased production of VLDL, increased clearance, increased plasma and hepatic lipoprotein lipase activity. Fibrates decrease total cholesterol, LDL, triglycerides. Fibrates increase HDL. These drugs do not produce substantial reduction in LDL, so that's not appropriate as an initial monotherapy. So remember, fibrates do not produce a substantial reduction in LDL, so it's not an appropriate medication for monotherapy as initial medication or monotherapy. So fibrates is like gemfibrozil, 600 milligrams twice a day. These may cause some nausea, diarrhea, maybe some cholelithiasis, or some phototoxicity. Bile acid sequestrants, those work by promoting an increase in bile acid excretion. They enhance conversion of cholesterol to bile acids by the liver and increase uptake of LDL. They bind with the cholesterol in the intestines and are not metabolized by the liver. They are excreted in the form of feces. These can be used with patients with active liver disease. So remember, if your patient has active liver disease, bile acid secretions is the first choice that you would want to use. They do have a strong record of efficacy and safety. Most useful for patients with moderately elevated LDL levels and low coronary heart disease risk profile. Also, patients who are not able to reduce their LDLs with lifestyle modifications, this may work. And this can be used together with fibrates. So a little bit about bile acid sequestrants. They may cause some, GI upset, maybe some headache. It reduces folate levels if with long-term use. So how do you take bile acid sequestrants? They mix a packet with juice. Never, ever, ever swallow it dry. This does interfere with the absorption of some other medications. If your patient is on bile acid sequestrants, you do need to monitor their lipid levels. They may have some bowel issues. Teach your patient to take this with meals mixed with 4 to 6 ounces of fluid, and to be careful because of the absorption could be impaired if they're taking something else at the same time. Okay, we'll talk a little bit about diuretics. So, there's a thiazide diuretics, that's hydrochlorothiazide, chlorthalidone. High dose therapy is hydrochlorothiazide greater than 50 milligrams. That would be considered high dose. And with that comes an increased risk of hypokalemia, an increase in uric acid levels, and some serious cardiovascular outcomes. And they're used in combination versus pushing high doses. So usually these doses are mixed with other medications, not just given by themselves. Loop diuretics, there's a potential for cross sensitivity with sulfa when someone's taking a loop diuretic. Loop diuretics are like furosemide, bumetanide, furosemide. And the potassium-sparing diuretics are often used in combination with thiazide to reverse low potassium effects, and that's triamterene and spironolactone. Some of the adverse drug reactions are hypotension. They may have a decreased GFR, hypo or hyperkalemia. One of the major CYP3/4A substrate effects would be a decreased effect with NSAIDs. The drug effects increase with grapefruit juice. So remember we talked about grapefruit juice earlier, and calcium channel blockers. You want to have your patient monitor for blood pressure, heart rate, weight gain, dyspnea, cough. Want to monitor their urine output. Prior to starting on a diuretic, you should have your patient's BUN, creatinine, electrolytes, uric acid, and glucose levels evaluated, and then continue to monitor while they're taking these electrolytes. While they're taking the diuretics, you need to continue to monitor their electrolytes. Tell your patient to take this medication early in the day if they don't have any issues with their urination. Don't skip or double a dose, and make sure they're monitoring their weight and tell them they have to drink fluids. A lot of patients on diuretics don't want to have to keep going to the bathroom, so they won't drink fluids. Okay, that is the end of this lecture for this module. And again, this was this was drugs affecting the cardiovascular and renal systems, part 1.